So my name's Murray Leikis. As Francis says, I'm a renal physician down in Wellington, or kidney specialist, working with adults. So a different field really to a lot of other people who work in paediatrics with TS. But I'm really going to talk about kidney stuff. And some of you will have heard much of this before. I have changed the talk from the last time I gave it 5 years ago. So some things I'll skip over very fast, and some I'll take a bit more time over. So thank you first to Helen for your lovely talk this morning. I actually found it, quite moving, because there's so many familiarities in the talk, and I'm sure everyone else here has the same thoughts and feelings. Firstly, TSC. So multi-system disease, you've already heard some of the stuff this morning already. It affects all parts of the body. The little bit I deal with is right down the bottom, the kidneys. And I put it down the bottom there because it's one of the things that comes on in adulthood rather than pediatric stuff. A lot of the other things happen in childhood years. So, the pediatricians are not dealing with it so much, but they do deal with it a little bit. And this slide, you'll see similar things in all the talks really, just shows the amount of stuff, so the percentage of people who have these issues in the different colours, different parts of the body that are affected at different ages. And so I'm dealing with this line here. I've got my colour right. So by the time people get it, they're into adult years. But you can see things come on at different times, and part of that is one of the reasons we really need the whole transitional care stuff as well, which Leila will talk about, because things change, and we may have someone being dealt with by a paediatric neurologist dealing with brain things. As they move into adult years, that might have settled down, their seizures may be well controlled, and then in adult years they're moving over to the kidney stuff perhaps as their more dominant thing. So transitioning is not just shifting from paediatric to adult care, it might also be transitioning from different services. This is really just to doctors out there who hear these talks. We have to be aware the sort of things that are affecting TS patients. And this is a lot about the behavioural stuff. Now, of course, a lot of people with TS have got completely normal brains and everything works well, but many don't. And there's autistic things we've heard about today, ADHD, depression, anxiety, phobias, learning difficulties, and when we're dealing with patients. We have to remember these things when we're treating people. So you've heard a little bit about the science, and I'll skip over that quite quickly. 2 genes, you can have an abnormality in one gene or the other, it still presents the same sort of way. In most cases, 2/3 of cases, there's no family history. And we've seen slides like this before. In the end, what happens is you get too much growth of cells and they turn into tumours. So kidneys, this is a bit I deal with. What do kidneys do? So kidneys do all sorts of things. They're really complicated little organs. They clean your blood and remove the waste products from your body. They help control the amount of water in your body. So all the cups of tea and coffee you're having now, it's going to eventually get through the kidney and you'll pee it all out and hang on to just the amount of water you need. It helps with bone health, and it helps regulate things like sodium, potassium, calcium, blood acidity. It regulates your blood pressure, and it also helps to produce your red blood cells so people with kidney disease can get anemic. So what sort of things do we see in TS? So the big one up the top, angiomyolipomas, that's the big tumours that we see and all hear about, and the biggest thing that people know about with TS. So the numbers at the end are percentages just on a survey at any one point in time, the number of people who had these sorts of things. But AMLs, which we call them for short, because A is for angio, so that means blood vessels. M is for myo, which means muscle cells. L is lipoma, mean fat cells. So AMLs is what we call them, and these tumours are made up of blood vessels, fat cells, and muscle cells. So they're called AMLs, angiomyolipomas. At any one time, almost 50% of people have got them, but we know over the lifetime, 80% of people with TS will have these tumours. Other cysts, which look like little blisters on the kidney, up to 20% or a quarter of people. Polycystic kidney disease, this was a high number for this survey, 3.5%, it's often down about 2%. Another condition that is not TS, but it happens, and I'll talk about that in a minute. Blood pressure, an under-recognised problem, at least 10%. Kidney stones happen. Kidney cancer is one thing that people don't like to think about. It does occur, but very rare. And then chronic kidney disease or kidney failure is another thing as well that can happen. So we'll go through a few of these things one at a time. So polycystic kidney disease. This is what I've called double trouble. Because on the genes, on your chromosomes, one of the TSC genes is right next door to the gene for polycystic kidney disease. And this is a disease where you get a whole lot of cysts on your kidneys and your kidneys get really big, the size of footballs. And as a result of that, your kidneys can fail. And this is seen in about 2 or 3% of people with polycystic kidney disease. So it's an unfortunate situation. And I've dealt with people with this before. And these patients often need kidney transplants later on in life as well. So a rare thing, but something to recognise. And again, the polycystic stuff comes on in adult years. Kidney stones. So hopefully people with TS won't get kidney stones, but it's a common thing in the general population. It's also a little more common in people with TS, mainly probably because of things like medications and dietary things that people have to go through. So when you're on the ketogenic diet, you get changes in the urine composition, which means you can get more likely to have stones. And a medication for seizures, topiramate, can also increase your risk of stones. So something we just have to be aware about. And when people get a kidney stone, they get pain from their loin, their sides area, right down into their groin. And it can be really, really painful. But fortunately, it will rapidly go when the stone passes, and we have to keep people well hydrated, so drinking lots of water. Kidney cancer, a rare thing, only 1% or less than 1% of kidney tumours in TS. The challenge with this is we do all these scans looking at kidneys, and it can be really hard to determine what's an AML or benign, not harmless, but benign tumour versus a cancerous tumour or a malignant tumour. And sometimes the cancer ones, the only way they look different is they have less of that lipoma part, less of the fat part in the tumour. Occasionally we'll do a biopsy of a tumour just to make sure. And if it is confirmed as a kidney cancer, it does need to be removed. That's the best way of dealing with it. Blood pressure or hypertension, an under-recognised feature of TS. People think of it as just a normal part of ageing, but it's more people with TS will have high blood pressure. And it's thought to be due to all sorts of things, but a feature of the TS itself, not just of the tumours, although the tumours contribute to it, as do the cysts. We can treat it with any blood pressure pill. You don't have to use any particular pill for it, but we have to be aware of medicines called the ACE inhibitors, ones that end in pril. So there's Accapril, Perindopril, Lisinopril, there's all sorts. There's a little bit higher risk of people having a swelling condition of the tongue with it as an allergic type reaction when you're on everolimus or sirolimus. So just have to be a little bit careful. And if people have high blood pressure, we have to be aggressive with treating it because it can worsen your kidney function just by having the blood pressure. It also worsens other health problems like heart disease and strokes, which is the same in the general population. Chronic kidney disease, or what we call, if it gets really bad, end-stage kidney disease or kidney failure. And this is largely caused by the damage from the tumours or cysts or the blood pressures, but there's probably just a feature of the TS itself, which means the kidneys slowly get worse over time. And you can read down the bottom there, if people get kidney failure, it's about 30 years earlier than the rest of the population. So if people get kidney failure, the average age is in their 60s. If people get it in TS, it's down in their 30s. So, it's rough. If they do get it, it's disastrous, but we do have options. We can do dialysis, which is a big deal, or kidney transplants, either from a family member or friend who's alive and can donate one of their healthy kidneys, or from deceased donors. So let's do a little bit more about these angiomyolopomas, because these are the main thing we deal with. And sometimes you can see the mess of this. This is an MRI scan. All those black bits are big tumours, and it should all be nice and even and grey, but it's absolute shambles. So AMLs. 80% of patients are going to have them. That's a lot of patients will get these. And we call them benign tumours, meaning they're not cancerous. But benign doesn't mean harmless. And the harm they cause is they can grow and cause damage to the kidneys. they can also bleed, which is a big problem. If they bleed, that can lead on to other more worse kidney failure. But majority of people are not going to have issues from their AMLs, especially if they're treated. And when it comes to AMLs, this is where size matters. If it's less than 3 centimetres in size, you're unlikely to have problems such as bleeding. So small tumours are okay. How do we look for them? We do scans. And usually we can't feel these things. So if the doctor doesn't examine your tummy, it's not that they're a bad doctor. They just know that they're not going to feel these things. They'll do a scan anyway. We can do ultrasound scans. So the cold jelly on the tummy doesn't hurt. It's an easy, cheap scan to do for the public health system. But we don't always see all the tumours. If they've got lots of fat, we can easily see them. We can do CAT scans or CT scans. And these are accessible as well, but you have to have a dose of radiation from that. So we don't like doing them all the time. Occasionally fine, but if we can avoid doing repeated ones, it's better. Again, good for most tumours, not so great if you've got low fat content in them. And that's where the MRI scan comes in. So this is the most expensive one. There's less MRI machines around the country, so it's harder to get scans. You often wait months and months and months. Some people get claustrophobic. Remember at the beginning I said people have phobias and things like that. So going the MRI tunnel can be quite difficult for some people. But it's the best type of scan for distinguishing different tumours. So what we're looking for is whether the tumours are growing over time. Are they going to get bigger than that 3 centimetre mark? They will grow slowly. 1 millimetre a year, 2 millimetres a year, maybe 5 millimetres. If they grow more than 5 millimetres in size per year, that's a little worrying sign to us to say, is this one a cancer perhaps? So we have to pay a little bit more attention to those. So usually grow very slowly. And if they're growing, what do? And this is where the mTOR inhibitors come in. We hear about these, sirolimus and everolimus. So this is way back in 2008, long time ago now, the first sort of published study of sirolimus in AML, so kidney tumours. And here they gave a bunch of people, there's about 28 of them, I think, maybe half got the sirolimus, I think so, yeah. They gave it for 12 months and the tumour shrank. And everyone thought, oh, wow, this is magic. And that picture shows them going down for 12 months. Then they had to take them off the medication and saw what happens. And they stopped the medicine, tumours grew again. And they had all sorts of pictures in the paper showing some of the tumours either disappeared or shrank down completely. A few years later, 3 years later, another group tried to say, well, that group did it. Was that results real? They did the same sort of study. Gave a few more patients. Exactly the same thing happened. Treated for 12 months, tumours shrank, stopped the treatment, tumours grew again. And that one, for those who want to know about dosing and things like that, they gave sirolimus at 6 milligrams to start with and then 2 milligrams a day if anyone were on it, and they aimed for blood levels of 3 to 9. But they aimed a little bit higher if they monitored these people, and after 4 months they didn't see a response. They gave them a bit higher dose. And we're still not sure if those are the right doses or not. And unfortunately it's a bit dark, this slide, but the tumours there's a picture showing one of them just halved in its size. It's a great response. Then the big study which came out in 2013, the EXIST-2, we heard earlier about the EXIST-3 one. There's EXIST-2, there's also EXIST-1. So this is using everolimus. So everolimus and sirolimus, sister drugs if you like. And they had to do a big trial like this, a more formal trial where they randomised or gave half the group, in this case 2/3 of the group, everolimus, and 1/3 a sugar pill or placebo. No one knew which one they're on, then doing tests all the way. They have to do trials like this in order to get the medications funded. So they looked at adults who had tumours more than 3 centimetres, and they gave them 10 milligrams of everolimus, and they adjusted the dose based on side effects, how well people tolerated. And then they said at the beginning what would be a definition of a response. So a response was if the tumour went down by half in its size. And if the tumours progressed, they had to grow by a quarter. I said adults, they were about 31 was the average age. And the response, almost half the people and that should be 24 months at the end there, half the people by 1 and 2 years had shrunk their tumours by half. And in the sugar pill group, none of them had. So a huge difference. You don't get trials this effective. And the tumours shrunk in the first 3 months. So very quickly they shrank down. And if you change that, instead of halving, if you make it only a 30% reduction in volume, 80% of people have responded. So very, very effective. And this is the picture down the bottom showing how they all shrunk. There's 3 people whose tumours did grow, but later when they went back, those people had come off their medication at some point. I put this next slide up. You don't have to read all the detail. This is what they put in studies to show all the side effects. And unfortunately, with everolimus, sirolimus, side effects are a big problem. A big problem in terms of lots of things occur, but not a big problem in severity. And if you dose adjust things, it comes down pretty well. The main things are oral mouth ulcers, little rashes, things like that. And usually it's all quite easily dealt with by changing the dose or having a few days off the drug. So most people stayed on the medication even if they got side effects. We want to shrink those tumours because we want to avoid bleeding. All right. So down the bottom, there's a little bit of blood. So this is what we call an angiogram. They inject some dye into your veins. That goes around the body, and we can see that lining up the blood vessels, and some blood coming out of that kidney. That kidney's bleeding. And so if something's bleeding, the first thing we do these days is try and embolize it. That means block that artery. Put something in it so blood can't get down. So they've done that, and there's no more bleeding in the second picture. But the problem is the bottom half of the kidney's now missing. You block an artery, you kill off a lot of the healthy tissue as well. And so we lose some kidney function by doing these procedures. But it's effective. So we can do that if something's acutely bleeding at the time. Sometimes bleeding just settles by itself. We can use all sorts of things to block the artery. It doesn't really matter what we use. So we can do it when something's bleeding. There's a lot of people who would advocate or say we should do it when you've got a tumour that's more than about 4 centimetres in size, because historically these ones are the ones that are going to bleed. About half the time, every 3 or 4 years, a tumour more than 4 centimetres will bleed. Or if there's a little aneurysm, a little outpouch on the artery, that'll bleed as well. I say historically because things are changing. Patients have been on everolimus or sirolimus, tumours have shrunk, but they may still be bigger than 4 centimetres. But the bit that has shrunk is the angio part, the blood vessel part, rather than the fat part. And it's the blood vessel bit that bleeds. So if the tumour's shrunk and it's still that size and it's staying that size, we may not go in and embolize it, we'll just watch. If we embolize things, I say we lose kidney tissue, but also it's an uncomfortable procedure. It's sore. People feel sick, they can vomit, you get a fever. We have to give steroids for a couple of weeks to minimize those symptoms. So it's not a comfortable thing to have done. And we also know now that even about a quarter of the time, even if you block off that artery, a little bit of that tumour might exist on the edge and they'll grow again. So 25% will recur. The main thing with bleeding is you tell the doctors you want to try embolization and not just go straight to surgery. Way back when, we would have just gone straight to surgery and we'd have removed that whole kidney. Suddenly you've halved your kidney function. The other kidney's got tumours in too, that might bleed. If you remove that one, then we're in trouble. So do embolization first. If we have to do surgery, we do what we call minimally invasive surgery. We only take a little part of the kidney, not the whole kidney. And we know that it's successful to use mTOR inhibitors, everolimus, sirolimus, over time. So those studies that we had before exist too. When they look back for patients once they've been on treatment for 4 years, none of them had had any bleeding. And the tumours had stage shrunk, so 85% had responded. 9 of them hadn't, but they had stopped their everolimus. So people stay on these things even when they got side effects, and they work. They don't bleed afterwards. So just what's happened with everolimus, sirolimus. So it was approved. That study was published in 2011. A year later in America, they approved everolimus for treating AMLs. In Europe, it was followed, and then Australia, 2013. Poor old New Zealand, we still don't have everolimus funded for AMLs, for kidney tumours. Everolimus is funded for the brain tumours, the SIGA, and we have sirolimus funded for AMLs and now for seizures as well. And that's only been in the last little while, thanks to the work of Helen and the team at TSNZ. So sirolimus versus everolimus, there's no study showing one is better than the other. Everolimus was funded overseas because everolimus did the big study. There hasn't been the same sort of study with sirolimus. So that's why those other countries haven't funded it. But New Zealand has Pharmac, and they look at all the things, and they look at how much things cost, and they'll say, well, sirolimus is way cheaper. And this is the difference. A 2 milligram tablet of sirolimus costs the government about $5,500 a year. If you're on 10 milligrams of everolimus, $79,000 just for the medication. So these are expensive. And that's why Pharmac have held off funding everolimus for AMLs, because AML's a big group of people. And at this stage, if you're on it, you're going to be on it for life. So it's a lot of money. Just so you're aware what doctors go through, we have to apply for these special authorities to get the approval funding for it. And if you have a kidney tumour, you apply for it, it's valid for 6 months. That means it's $5 prescription fee or free if you've got a community services card for you guys. You have to show that you've got a kidney tumour more than 3 centimetres. You can't just have one that's only 1 centimetre and say, oh yeah, let's get onto this and make sure it doesn't get any bigger. It has to be 3 centimetres already. And then after 6 months, you have to apply again. You get a further 12 months funding, and you have to have another scan showing that it's shrunk and that it's still effective and the patient's tolerating it. We have to tick all these boxes on the form. And then we're going to do that every 12 months. And that's why every 12 months you have to have a scan to make sure that we're not telling untruths on the boxes when we're applying for things. Same thing for seizures, same thing for everolimus. But for everolimus, it's only 3 months the first time round. And then after that, you have to have more scans. So there's a lot of scans for people as well. So fortunately, all the various societies around the world have given us guidelines. New Zealand's got really good guidelines telling us what to do. And this is where, unfortunately, because people have to advocate for themselves, you go along to your GP or your paediatrician or your kidney specialist or neurologist and say, this is what we need to do for my family member or myself with TSC. For kidneys, when it's first diagnosed, we want an MRI of the tummy, looking for cysts and angiomyolipomas so we know how often to follow things up. We also want to check the kidney function, which is a blood test, and the blood pressure. And then later, if you know the diagnosis, then you need to do a scan every 1 to 3 years, depending on what's going on. If there are no angiomyolipomas, you can wait 3 years before you do another one. If you've got them, you do them every year. And ideally an MRI every year. As mentioned before, if you've got head things that need scanning as well, do them together at the same time, especially if you need general anaesthetic, and we'll hear that multiple times. If an MRI is difficult to get or the tumours are not growing, instead of doing an MRI every year, you might be able to do an ultrasound every alternate year, every 2 or 3 years, just to monitor things. So we don't have to do MRIs, but that's something that you'll discuss with the doctor. What's the best way for your patient? And then if you have angiomyolipomas that bleed, embolizing them. If you're on an mTOR inhibitor, then we have to do blood tests every few months until people are stable, and then every 6 or 12 months, looking at kidney function, cholesterol, blood levels of the drug itself to make sure you got the right dose. We've got lots of protocols about how to use medicines like everolimus, which most doctors won't have ever heard. And there's things like this where I've mentioned you need to do blood tests every while. We have to adjust for side effects, so dose adjust. So you may start on 10 milligrams of everolimus and eventually go down to 5 or even 2.5 milligrams. And that's where monitoring with repeated scans to see if that's still effective. We don't know what the actual best dose is. We're only going by what the big studies have used. If people are having operations, we often need to stop the sirolimus or everolimus for a few days beforehand because it can slow down the healing up of a wound if you're still on those drugs. I mentioned those things already. We have to be careful with some vaccinations when you're on everolimus or sirolimus, what we call the live virus vaccines. That's not COVID. We can have COVID vaccinations, but they may not be as effective when you're on these medications. And there's already talk now in the research journals We might need a dose of a drug to treat tumours, be it a brain one or a kidney one, and then a lower dose to maintain shrinkage of that tumour. We don't know all that detail yet, but people are working on studies now to try and work out that. And it may be you only need a dose every few days rather than every day if you're just trying to maintain things. Side effects, we've mentioned, really common. And if any of you are on these medications, you know all about these: mouth ulcers and acne-like rash. So you've just dealt with your angiofibromas on the face, and then you get an acne-like rash from the drug. Headaches. Inflammation in the lung is a nasty one we have to watch out for. High cholesterol. It can alter women's periods. And then these drugs interact with other medications as well. Pregnancy. This is becoming something we're going to have to think about more and more as women want to have children who are on these medications. We don't really know what to do yet. The recommendations from MedSafe, the people who monitor these drugs, are to say that one should not get pregnant on these medications and should be off these medications during a pregnancy. And that's largely because we don't have evidence about how safe it is. They can give it to rats and mice and things like that, and at high doses it can cause problems in the babies. But in humans, the various papers where people might write a report so far haven't found problems with pregnancy on everolimus or sirolimus. So ideally, if we can get away with not being on the drug during a pregnancy, that would be best. But if we have to have it because that's controlling something that we know will change if we come off it, then you may decide to stay on it and just watch things really closely through the pregnancy or try to use a lower dose. So we still don't really know what to do, but it's an area that's going to become increasingly questioned. So, kidney problems, common. More common in adults than children. So all patients should see a kidney specialist at some point. That might be during transition, it might be well into their adult years, but they should see a kidney specialist to know what to do with kidneys. There's good guidelines to follow. Blood pressure is common, but it's easy to treat. The growing AMLs are the ones we worry about, and they need to be followed. And our first line treatment, which is here in New Zealand, would be sirolimus. Some people are on everolimus. We can occasionally get funding for that if they don't tolerate sirolimus. Dose adjustment is often needed because of side effects. And we need to protect the kidney function at all possible. We don't want to develop kidney failure. So where are things going in the future? Because all this seems like it's, I could have said similar things 5 years ago, which I did. There are newer mTOR inhibitors being developed. Not available yet on the market, but people are looking to see, can they develop similar drugs to everolimus, sirolimus that don't have the same side effects, that are better tolerated? Researchers are looking at other medications, and we heard like in vigabatrin versus everolimus, working on that mTOR pathway within the cell, working on a different angle to see if we can affect something else to have the same result. I was reading about something where there's a dual treatment. You give a medication that blocks that mTOR, but it will block the mTOR thing in the whole body, and we might not want that. We might want it only to block it in the brain to stop a brain tumour growing. So you can give a combination drug where the second part blocks the effect of the first drug and elsewhere in the body, so that when that drug enters the brain, the second one doesn't enter the brain, so it only works in the brain. So there's all sorts of ways people are looking at trying to use medications to get to where we want it to be. People will ask about gene therapy. This isn't on the market yet, but we can splice genes, we can dice genes, we can do all sorts of things. There's treatments that we can use where effectively you put an enzyme in the body that goes along like a pair of scissors and cuts out a part of the gene that we can magically target, and you can put a new gene in there. So people are saying, well, hang on, can we do that to help things? And as Claire said, unfortunately, when people are born, they've already got the TS, so we can't stop that just yet. But maybe we can stop things changing as children and adults grow. So work is still going on in that area. Whatever happens, New Zealand is always going to be a bit behind. We're a bit slower here with our funding. But we do catch up eventually. And from my perspective, I'm hopeful over time that we're going to see less and less problems with things like AMLs. We're not going to see the big tumours. We're not going to see people develop kidney failure because they're on these medications earlier and at a younger age, so they're stopping these things getting to the bad points we used to see before. And this is what I want to say. Thank you very much. So I'll hand over now to Leila, who's going to talk about transition. And I hope the AV person will change the slides.
I'm vertically challenged, so just... Thank you for inviting me into your space. I really appreciate being here. So I'm another adult nephrologist. I'm going to talk about transition care, which is a precious time for precious people. Which one is it? Okay, there we go. So just a little bit about me. As I said, adult nephrologist. I spent 8 years in the pediatric liaison and clinician role in the Hutt and Wellington region. Transition ages differ depending on where you're from. In the Hutt region, it's 15 years of age, and in Wellington, 16. It causes quite a bit of problems in terms of how we hang on to patients, we'll pass them on. But I have been very privileged to meet lots of TS patients in the Wellington region and care for them and their families. And in fact, Murray and I have been the only two who've seen the TS patients and families in that region. So it's important to know that transfer and transition is not the same thing. Transition was defined nearly 30 years ago by the Society of Adolescent Medicine as the purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered to adult-oriented health care systems. And transfer is the event that takes place at the end of that process. There's a wealth of information about poor outcomes if you don't have a transitional service, and that's a whole talk on its own. But there's lots to look in terms of diabetics with end organ damage, end up on dialysis, renal transplant recipients who have don't look after their kidney transplants, end up back on dialysis, and so many other facets of medicine. And unfortunately, that leads to high financial costs. There are lots of different transition models and clinics that have been used over the years. And I'll just point to the last two. The overlap and alternating visits has been the best approach in my experience, and hopefully getting a joint adolescent and young adult clinic. So in the New Zealand model of care, we have young people with chronic conditions. They're seen regularly by their general paediatricians in their regional centres, their paediatric specialists, and the associated MDT from the Starship Hospital are involved in the more complex cases. And after the transfer of young people to adult healthcare, the structure may change. So it might be shifting key contact to the primary care physician, their GPs, with longer periods of in between seeing their specialists, or the primary care coordinates between multiple adult specialist clinics. In the Wellington region, we would meet the children and their families in the joint Starship Pediatric Nephrologist, which was with originally Tonya, so we do miss her quite a lot. She was very observant and kind, and whenever she knew this one particular child would come to clinic, this kid was obsessed with the colour purple. Tonya would wear purple on that day, so it was really sweet. And we had Chanel and also Amanda more recently, and also a local adult nephrologist being me and the local paediatrician. Sometimes you meet them as young as 5 years of age, but it's usually around the 8 to 12 year of age period, so they get used to seeing you and also with their families. We alternated visits from the age 14 and kept that up until 1 year post their 15th or 16th birthday, depending on the age of transition for the hospital. The timing of appointments, I would offer them, early first one in the morning or after school. Most would choose after school. And do split appointments, so a joint appointment with the parent and then ask the parent to leave after a period of time so the child had time to talk to you on their own. And often the appointments would be 60 minutes. I would also allow them access to text me if they were a child of age, the parents as well, or email or phone, because we have to remember that funds are scarce and going to a GP for repeat prescriptions very expensive. So for me to do a script doesn't cost much, 2 minutes of my time, if that. The only shortfall is that the environment was not sort of a fun and adolescent-like space, although Te Wānui, the new children's hospital in Wellington, has a little area for youth group activities. So I'll just talk about this qualitative study that was done by Claudia Vallabella. So she was the pediatric fellow, and as part of her registrar attachment to the Ministry of Health, Ross, who's a pediatrician, and I supervised her study. So it was called Transition from Pediatric to Adult Renal Services, Their Voices. And it was done within the Hutt and Wellington hospitals. And as I said, it was a qualitative study. Wanted to capture the experiences of young people transitioning or who had transitioned from the pediatric to adult renal services, to try to identify expectations, unmet needs, and any areas of development in the existing transition program, as well as gain understanding of supports needed and how we could improve those. And we ended up with 10 young people with chronic kidney condition, and they went through semi-structured face-to-face interviews. We had 6 males, 4 females, age range of 14 to 22 years. 7 adolescents attended school, 2 were enrolled in university, 1 didn't do further study but worked part-time. And there are multiple questions, and these are all fairly standard questions if you look at all the qualitative studies. We ask, what do you know about your diagnosis? How has your kidney disease influenced your life? Describe the transition process, what it's been like for you, when you thought it started, and was the timing right, and many other questions related to that. Do you feel well informed about your kidney condition? So if you look at the table, that was the ethnicity breakdown. We did have 2 Māori, 1 Cook Island patient, 1 Indian, and Latin American. That's the renal diagnoses, and unfortunately you can see we didn't have a patient with TS on that group. But the themes that emerged from this qualitative study, the first one is knowledge is power. So in terms of unmet information needs, there was great variability among participants, but all participants wanted to be in control of the amount of information that they received. Majority of the younger participants rather wanted limited information, as they found too much information being scary. And this one quote, I think I'm more towards not worst case scenario, because that's not ideal to think of. But yeah, I would definitely want to know risks if it would impact any decisions in the future. Transition information. So few participants understood the concept of transition. Young people were aware of the approaching transfer to the adult health service, but not the reason for their joint appointments. In particular, they didn't feel involved in the planning process. They felt it was something that happened to them rather than something they were actively part of. A couple of quotes. I felt like they should have told me maybe when I was 15 going into the adult world. That would have been good. Instead of telling me straight away when I'm already in the adult cycle. They could have told me a year before. Another one, I felt like I didn't get a warning or anything. This is what would be your last year since you're allowed in here, and then you have to move from pediatrics. I was 17 and they told me that I have certain stuff where most of it you have to do it yourself, Understood none of that, and my parents explained it to me. Next, within the theme of knowledge and power, was web-based information. All adolescents valued the role of internet resources about their disease, but they were worried that the information may be unreliable, and they wanted access to concise and trustworthy information that they could access independently. Yeah, we're the next generation, so everything, it's all internet-based, not much book-based. One just wants to skim and scan, just wants to read through the lines and go straight to the main point on what this has to do with your body and all that. It would be great. The second theme was shifting the center. So adolescent-centered versus family-based appointments. Adolescents felt that most times the appointments weren't directed at them. They described how most of the questions were directed to their parents instead. They often didn't know why they had an appointment and felt like it was just a waste of their time. They're missing school and missing out with time with their friends. They also felt their parents' presence during the whole length of the appointment was often perceived as a communication barrier. So one quote, yes, like when my parents were in here and it was him talking a lot, I was like, okay, I'll just sit here and stay quiet, because like that happens a lot whenever I'm with them. It's just, yeah. Adolescents felt undermined by their parents and censored from conversations. Some parents pressured patients not to have appointments by themselves. And several patients expected their doctors to advocate for their right to have a chance to talk by themselves. One quote, my parents said no because we're family. But I also personally, I believe that there are some things that a child must communicate by themselves, because having parents around can, for me, it was a little bit daunting. It's not anymore, but it can be a little bit daunting. So I think there are some instances where the patient has to talk to the doctor. Control. Young people wanted to gain some control of the situation. One participant recalls for a long time didn't talk to the medical profession at all, and said that that was the only thing I can control. Despite the fact that young people wanted a more adolescent-centered appointment, they still wanted the parental support. A planned split appointment where the adolescents could have time to talk to the doctor was an appealing model for most young people. And a participant described how changing to the adult physician gave her an opportunity to have her own doctor-patient relationship, and because she viewed the pediatrician as being in a relationship with the parents. And she said, I think I found it a bit weird, but I think switching between like doctors actually helped, because like my parents have been talking to the doctor I had since I was not even born. And just like talking to someone like fresh was actually good, because I didn't really have like that history of not talking to them your whole life. Readiness. Young people did not consider themselves ready for the transition process. Adolescents were conscious and apprehensive about the change. They struggled to understand why they were considered adults in the health system, as they felt poorly prepared to navigate it, and they felt forced to grow up. Most adolescents and young adults didn't feel confident making appointments or requesting repeat prescriptions or being admitted to the adult ward. It does kind of feel like I'm getting kicked out, and I mean I'm only turning 16, and it doesn't feel like I'm an adult, and it just feels like I'm getting kicked out. Like if it were up to me, it would be 18, because me and Mum talk about this a lot. And we're like, if you can't work till you're 18, then why are you being moved to the adult ward at 16? Older adolescents were self-critical about their knowledge. They did regret not using the time in pediatrics to prepare themselves better for the adult services. They regretted having missed years of information and interaction with their health professionals by zoning out during appointments, just sitting on their phones. And some felt they knew just enough to get by. Familiarity. Young patients describe being overwhelmed by names and appointments when too many professionals are involved. But over time, by knowing and trusting the doctors, the fear was reduced. The third theme is support needs. So parents as allies. Young people needed support to cope with the burden of disease and their medications. They relied on their parents for information, management, but most importantly, emotional support. When it came to questions around their friends, the support of their friends and relatives had a positive impact on their experience with kidney disease. They had disclosed their condition to their friends and relied on them for support when they were struggling. Peer support. The idea of sharing experiences with other young people with kidney disease was controversial. Adolescents' priority was a sense of normality. Some young people argued against peer support because they disliked the idea of using their disease as a reason to meet someone. They often expressed the desire to feel normal and socialize with normal kids. Those adolescents who were interested in peer support had an evident sense of wanting to belong. I guess it's just meeting people in general. I don't know. I guess I don't really find it that easy to do, but I guess it would be cool to meet other people with the same kidney condition or whatever. Another participant said, it would be amazing to meet someone like me, someone who's the same. Oh, but now is that I'm really embarrassed of this. Every time I talk about it, I feel embarrassed. It's just that I don't feel normal. So we've been doing transition clinics for quite some time, and despite all of that and our best efforts, we had quite a lot to learn from it. And we found overall that early, gradual, tailored, and specific information about the transition process is really important, and also talking more about adult services, what they might expect, how different their appointments might be, and the interactions as well. We found that learned and gradual independence and self-care needs to be supported a lot more. We should invest in creating web-based sources and chat groups that these young adolescents may be able to engage with. And this highlights the need for Ministry of Health, Te Whatu Ora, and local service policy for transition with a clear transition pathway, which is often missing across hospitals. Several of these points are applicable to young people with other chronic conditions, of course. So I found Trapeze, which is an Australian-based specialist adolescent chronic care service for the Sydney Children's Hospital Network. And it is government funded. I urge you to look at their website, which is quite a fantastic initiative. They support young people from the age of 14 to 25 years, living with a complex chronic illness, currently treated at Sydney Children's Hospital Network and have an unclear health transfer pathway. They help coordinate care, they help find GPs, they help young people connect with appropriate professionals, and also provide social and emotional support and links to support groups. Would be fantastic if New Zealand had something like this, given our smaller size. They have these great little tips and checklists for clinicians who aren't used to transition processes themselves or dealing with young people. But what about tuberous sclerosis? So the transition for patients with TS is complicated by the multisystemic nature, as we know, the age-dependent manifestations, and that's been discussed this morning, the high clinical variability and the presence of intellectual disability as well, the fragmented specialty care, especially in adulthood, and in adult care there is a lack of experience with patients with TS. People tend to be quite afraid to take these patients on, the fear of the unknown for the health professionals themselves. And in adulthood is often less family-orientated care. But it does require someone who's passionate, who understands both transition process as well as wanting to learn about patients with TS and their needs. There are lots of approaches that have been studied before, and they talk about stepwise approaches in setting up a multidisciplinary clinic for patients with TS. And this is from 2019, and as you can see on the left there, they say step one, start with a single dedicated physician who will drive the MDT development process, then establish a small core team, including a care coordinator. Eventually your multidisciplinary team will grow. So this is a study from Milan. So some parts of the world do this very well and have done it for so long, and others are lagging behind. So this was reported in the American Journal of Medical Genetics in 2018. Healthcare transition from childhood to adulthood in tuberous sclerosis. And since 2001, at this university in Milan, there was a group of physicians who were interested and also shared their experiences in caring for patients with TS. And the TS clinic was developed following the need for pediatric and adult neurologists at the Epilepsy Centre to involve other specialists in the care of these patients. And as you can see, there's a huge group of specialties that we need, whether it's a pediatric TS clinic or the adult TS clinic. We need quite a lot of specialties to sit on these MDT groups. And this was their process. So they had clinical managers on either side, so whether it's the pediatric TS clinic or the adult TS clinic. In the pediatric clinic, the clinical manager would be a pediatric neurologist or a pediatrician, and they will ensure that at the right time, which is around the age of 14, they start the transition process to the adult clinic. The clinical managers in the adult clinic were neurologists and geneticists, and they did it in this space called the DAMA, which was the Disabled Medical Unit. They had professional staff who then fed back all information between different groups, so there was continuous communication every 4 months between peds and adult clinics. And all that information was also fed back to the primary care physicians, the other therapists involved, and patient associations. They were seen as outpatients, and their clinics spanned 1 or 2 days. They usually scheduled 5 patients per week, but in the end, it ended up looking after 250 patients overall, just in that one region, 2/3 of which were adults. Admissions for inpatients were reserved for those who needed EEG monitoring or those who needed renal surgery. And on average, they received 20 new referrals for the adult TS clinic per year. And their numbers grew from a few dozens in the early 2000s to 250 by 2018. And that model allowed them considerable reduction in the travel burden each year, from generating many clinic appointments to just 2 clinic appointments, where you see every different specialty in 1 or 2 clinics over that 1 to 2 days. It improved quality of life for these patients, especially those with significant disabilities. They did have a combination of a mix of private and public funding, and as we know, funding is always an issue no matter where you are. This was and as I just said, things across the world is different. That was in Italy. This is a study, a Dutch study, and this is 2018. So although Italians had things well set up in their region, this study in epilepsy and behavior was another qualitative study. They wanted to explore concerns and care needs for young adult patients with TS in the medical, psychological, and socioeconomic domains. They had 16 patients, age range 17 to 30, and they interviewed 12 parents. And the main concerns involved mental, physical health, participation, self-management skills, side effect of medications. And the consistent theme, and you can look at several other papers, is that down the bottom, we need specific information around the transition period. That comes out consistently from each study. And also in this one was attention for parental stress, as they found high stress amongst carers, and that adult healthcare providers should set up expert MDT care. So even in 2018, this was lacking in the Dutch group. In the UK, and this was touched on this morning, the TS clinic in Bath is the oldest and largest in the UK and was founded by Professor John Osborne in the early 90s. There's a St George's TS clinic in London running since 1993. But they have more than 16 specialist clinics in the UK and over 25 in the United States. And we're aware of the Tosca registry that recruited over 2,000 patients from 170 specialist centres in 31 countries. And then in the Republic of Ireland, they have about 600 to 800 people that they estimate with TS, but they don't have any specialist MDT TS clinics either. And because of that, they did an audit. So they audited the care of patients with TS in 2 large specialist adult epilepsy clinics in Dublin and compared it to the UK consensus guidelines, again trying to identify gaps in care, to harness data to plan for improvements in care, foster an interdisciplinary network of care for each patient, and improve communication and ease of healthcare navigation. What they found, only 1/3 of patients had diagnostic genetic testing results available. Neuropsychiatry was largely neglected. Completion of these neuropsychiatric assessment checklists was inadequate. Discussions around sudden unexpected death in epilepsy weren't happening, and access to treatment was limited. There was variability in reporting of radiological findings as well. So once again, they found care is fragmented, difficult to navigate. There was a cumbersome inter-service referral rather than having a patient-centered one-stop clinic. It was quite wasteful of resources, and there weren't any support for families or health professionals. The National Rare Disease Office is in the process of developing a TS pathway, but they don't have any resources allocated to them. So we can learn from Australia, who's our closest neighbour, with a well set up clinic. Since 2014, the adult MDT TS clinic from Westmead Hospital in Sydney, and I think Jackie will probably talk more about that later. But they have a group of neurologists, geneticists, nephrologists, dermatologists, and anaesthetics in their adult TS clinic. And Dr. Zaibunisa Rahman, who's a neurologist, took over as the lead for this clinic in 2015. Their referrals are via the GP. And in 2015, they had 15 patients in 3 clinics, and they now have 5 to 6 clinics a year serving 50 patients. They do have a lack of funding for a full-time care coordinator because this person often has to work in the hospital and the community. It's not quite set up as a transition clinic, but it is linked in with the trapeze referral process and system of support for these young patients. And I think we would do well to follow suit if we can get enough resources together, and how to access that would be important. And finally, this is Libby, who's sitting in the back. We wanted to say how proud we are of Libby and all her achievements. You would have seen many pictures in the past of her doing athletics, and this is her doing her most recent passion of the last few years, CrossFit, and she's going to compete in Australia soon. So, thank you.